SARS-CoV-2 on pregnant women and their newborns. As such, I would like to present data from the COVID-19 related obstetric and neonatal outcome study, in short, CRONOS. My name is Nadine. I'm a neonatologist and pediatric intensive care physician, and I'm working in the Department of Pediatrics at the University of Marburg in Germany. I don't have any conflicts of interest to declare. CRONOS is a prospective registry coordinated by the German Association of Perinatal Medicine. It investigates the effects of SARS-CoV-2 infection in pregnancy on mothers and their newborns. In July 2022, almost 8,000 patients were registered, and this will be the base of an updated evaluation for the presented data, or the presented data, however, is based partly on a evaluation which we undertook in August 21, when 2,256 patients were enlisted and had already delivered their babies. We formed two cohorts based on the time of maternal infection for the analysis. In the early infection cohort, those women were included with SARS-CoV-2 infection more than 14 days prior giving birth, while the late cohort or late infection cohort consisted of perinatally infected women. About 60% of the registered women had a SARS-CoV-2 infection in their early pregnancy, and most of these women had experienced some sort of symptoms during their pregnancy of the SARS-CoV-2 infection, and about half of the patients with late infection, with perinatal infection, were asymptomatic. As demonstrated in the right column, critical maternal infections were mostly seen in the late infection cohort. Nevertheless, this was a rather small proportion of the overall cohort. You can see it's just 3.7%. And a woman was stated as being critically ill when relying on respiratory support, while being severely ill meant needing supplemental oxygen. The symptom severity affected the birth mode. More than 85% of critical ill women and more than 60% of severely ill women had a C-section. Overall, the rate of C-section, which was performed mainly due to SARS-CoV-2 infection, was rather low at 7%. This was lower than previously described in an early study of Knight and colleagues. There were rates up to 16%. In general, the rate of cesarean, regardless of maternal symptoms, was 36%. This did not differ between mothers with early or late SARS-CoV-2 infection and was not elevated in comparison to historic German data. It was lower, though, than in early systematic reviews, reporting C-section rates of 40 to 60%. However, even in those patients giving birth during the first pandemic wave of SARS-CoV-2, the C-section rate was low in Germany in comparison to other countries. Overall, about 13% of infants were born premature, in contrast to reported preterm rates ranging from 13 to 26% in systematic reviews. As medical indications are rarely mentioned in the report, it is difficult to differentiate between spontaneous and iatrogenic preterm rates, though spontaneous preterm birth rates seem to have decreased during national lockdown in some countries, as it was reported in Ireland or in Denmark. Also, a viral infection similar to bacterial infection can induce preterm labor and delivery. It remains unclear whether SARS-CoV-2 infection is a cause of or a coincidence in spontaneous preterm delivery. There are some really interesting studies going on. Obviously, there's one study in Canada who found out that preterm birth was more likely in pregnancies affected by SARS-CoV-2 compared with unaffected pregnancies during the same time frame, even among cases involving milder forms of infection. This study in Canada looked specifically at pregnancies affected by SARS-CoV-2. And there's another study here, which showed that compared to a mild COVID-19, severe COVID-19 was strongly associated with preterm birth, but still it's not clear if it's a coincidence or not. There have been concerns raised regarding a lower birth rate, especially in early infected women. We did not find any difference between both cohorts, and we didn't find a raised rate of small for gestational age newborns. And the rate of those SGAs was 7.1%, and this was even lower in our cohort compared to German historic data. There were also concerns of a higher malformation rate with early maternal SARS-CoV-2 infection, which we also don't see in our cohort. In our registry, there were 47 newborns with malformations, mostly cardiac or cerebral malformations, and most of those infants with malformations were born to mothers being infected during their third pregnancy trimester, which means at a time when the organogenesis is completed and when SARS-CoV-2 shouldn't really infect or have any impact on organs of the unborn child. However, there are some case reports of malformations, especially orbital malformations, which are thought to be due to maternal SARS-CoV-2 infection in early pregnancy. When we look at the postnatal transition, there's no higher rate in asphyxia neonates born to SARS-CoV-2 infected mothers, but there is a higher rate of admission to a NICU, which was 14%, and compared to the historic data, the historic German data, it's a 30% up. Or asked for the reason for NICU admission, 60% of the clinics specified prematurity or respiratory distress. 20 newborns were admitted to the NICU purely because of the maternal SARS-CoV-2 infection. This is not very high, but still those neonates were completely asymptomatic, but still hospitalized. Almost 50% of all admitted neonates received some kind of respiratory support. This is a rather high rate in comparison to 36% of all newborns admitted to German neonatal wards in 2020. This high rate of respiratory support was regardless of the time of maternal SARS-CoV-2 infection. And it's not really surprising given the reason for NICU admission. As previously stated on the slide before, more than 60% of the neonates were admitted due to prematurity or respiratory distress. So we actually would expect some sort of respiratory support. There was no difference in the kind of respiratory support. So we didn't find a difference in oxygen or non-invasive or invasive ventilation between those two cohorts. We see a pleasingly high proportion of children who are fed with mother's own milk and are also fed with mother's own milk in the short-term follow-up, which we did when the babies were 6 weeks old. All mothers who agreed to this were or we ranked those mothers and asked if they are still feeding with a mother's own milk, and the follow-up rate was still more than 80%, which is really, really high. These figures are well above systematic reviews, but we also see that children who are delivered by mothers with a late infection, regardless of being mildly or severely ill, were significantly less likely to be fed with mother's own milk. This is a difference we see in rooming in rates as well. The rate of rooming in late SARS-CoV-2 infection in mothers was much lower, or significantly lower than in early infection, in the early infection cohort. And this cannot be explained solely by the fact that neonatal inpatient admission occurs due to maternal SARS-CoV-2 infection. As you can remember, it was rather low. And at the same time, we see that the rate of positive PCR tests in neonates are very low. So we can clearly recommend, and have always been doing that, rooming in compliance with hygiene rules, such as hand washing, using of mouth, nose protection when breastfeeding, and physical distancing while sleeping. It's known that a lack of rooming in negatively affects stress levels and breastfeeding, and should therefore be avoided. In our cohort, we did neonatal PCR tests in 822 newborns, resulting in 3.6% positive PCR results. And most of those children were born to mothers with a late infection, thus meaning less than 14 days prior to giving birth. This is right in the middle of rates described in systematic reviews, which state rates between 2 and 8%. A positive test result does not equal neonatal infection, though. 6 of those newborns were ventilated, but 4 of those 6 were late preterms, being born about 34, 35 weeks of gestational age. And 2 of them were very early preterms, being born before 32 weeks of gestational age. So we actually would expect that those children might be ventilated. Most of these kids were asymptomatic. And in general, neonatal SARS-CoV-2 infection is often asymptomatic, so we can't really derive if it's an infection or it's just a SARS-CoV-2 positive PCR test solely based on the symptoms. And above that, respiratory abnormalities are non-specific and are pretty common, especially in premature babies. Therefore, they are not part of typical classification systems. There are a couple of different classification systems when describing neonatal SARS-CoV-2 infections. And we decided to use the rather strict definition or categorization of the World Health Organization. All of those different studies try to differentiate those neonatal infections between intrauterine, intrapartum, and postnatal. But above that, the WHO describes those transmissions as confirmed or possible or indeterminate. So that's what we did. We took those 28 newborns, this rate of about 4% of positive SARS-CoV-2 infected children, and tried to classify them. Of those 28 newborns, 3 were stillborn. In all 3 cases were positive placenta swabs available. And in only 1 stillborn, an additional fetal lung swab was positive. So this is a confirmed intrauterine transmission of SARS-CoV-2. Of the 25 live births, 6 had a positive PCR only on day 1 and negative results on day 2 or day 3 of their life. And this is a very common finding in newborns. This is well described in literature that a couple of newborns are positive only on day 1. And this is probably a result of maternal virus particle shedding during giving birth and doesn't reflect an actual neonatal infection. So we had 18 live births left to classify, and we could categorize them. As you can see, there were a lot of newborns being categorized as indeterminate transmission, 10 of them. And this was because there wasn't a second swab collected. They only had one swab, one positive PCR test, and despite of being symptomatic, there weren't second PCR tests available. And as it is important to be able to distinguish transient colonization without infection from true neonatal infection, confirmatory testing of a second specimen is required. So overall, of those 28 positive results, and about 40% we had confirmed or possible infections. We did a preliminary tests with the higher rate of registered women. In May 2020, we had 74 newborns who were tested positive on SARS-CoV-2. So we tried the classification of the WHO again. And 6 of those 74 newborns were stillborn, and 4 of those had positive placenta swabs. We had 8 newborns with positive PCRs only on day 1 and negative results on day 2 or day 3, so we couldn't count them into our transmission categorization. So we had 59 live births left, and 6 of those live births we didn't have proper data available even after contacting the clinic, so we excluded them. But we had 14 possible intrauterine transmissions and 9 confirmed or possible postnatal infections of those children. So again, about 35–40% of the initially SARS-CoV-2 positive PCR results were confirmed or possible transmissions while being pregnant or postnatally. So what can we conclude? SARS-CoV-2 tests in newborns do not equal neonatal infection. The incidence of positive SARS-CoV-2 tests is really low, and vertical transmission does occur, but is rare. And our future prospects are we're trying to integrate our registry into other international registers, and we're using the now established fit structures for further perinatal natological questions. This is the first time in Germany that neonatologists and obstetrics were working this close together, and we're currently starting to evaluate the current data, which the current data includes almost 8,000 women. So I'm hoping we're showing that, or we're trying to study those and have positive or interesting results in the upcoming weeks. And we also started a neonatal long-term follow-up. We are contacting the initially SARS-CoV-2 infected women 1 year and 2 years after their babies were born, and trying to differentiate if there were any difference in vaccines or vaccinations or in the developmental kind of state. Well, thank you very much for your attention. This is a very vast network being led by Ulrich Pex, who is working in the Department of Obstetrics in the University of Kiel, and Professor Rüdiger, who's head of neonatology in University of Dresden. Thank you very much.
Thank you, Dr. Nadine, for your excellent presentation. We hope everyone has learned a lot from this presentation. Do we have questions?